So thanks everyone for joining us for today's webinar. We're looking at the role of gender in helping us understand MS and looking at womanhood throughout the course of someone living with MS. Our presenter today is Dr Ruth Dobson and I'm your facilitator. I'm Andrea Salmon. We start all our programs by acknowledging and paying respects to the traditional custodians, past, present and emerging, on whose lands we meet today, no matter where we're dialing in from. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. It is my pleasure to introduce you to our presenter today, Dr Ruth Dobson. Dr Ruth Dobson is currently a clinical senior lecturer in the Preventive Neurology Unit at the Wolfson Institute of Preventive Medicine, Queen Mary University, London. She's an honorary clinical senior lecturer at Imperial College and an honorary consultant neurologist at Barts Health NHS Trust. She studied at Clare College, Cambridge and UCL before completing medical and neurology training in London, Birmingham and Sussex. Ruth was identified by the Royal College of Physicians as an emerging woman leader in 2019. We actually pre-recorded this webinar with Ruth. I recorded it with her last Friday when she had time. We figured the difference in time zones and everything would make it just too hard to be live. So hopefully this will all work, and I will share with you the presentation that Ruth prepared for us today.
Thank you for inviting me to come and talk about using gender to help understand MS. My name is Ruth Dobson. I'm a consultant neurologist in London in the UK, and I got particular interest in this area of research. So in terms of my disclosures, I've got grant support and honorary compensation from various pharmaceutical companies. I think also importantly for the purposes of this talk, I'm a female academic neurologist, and more so probably in the UK than in Australia, we're in fairly short supply. So what I'm going to talk about today is the huge amount of effort that's gone into uncovering the causal pathways to MS, but actually how in some ways gender has been neglected in this. Countless millions have been spent on uncovering these causal pathways, but it sometimes feels like there's incremental gains and the same topics are presented again and again and again. For example, vitamin D, Epstein-Barr virus, and they're presented in very similar ways. And when thinking about this talk, I've had a slightly winding route to some of the slides. I think one of the main research interests that I have in MS is causal pathways extending back to childhood and pregnancy. And like many researchers, I've just accepted the gender ratio in MS as fact. Women are more likely to get MS than men. That's just part of MS, so what? But more recently, over the past few years, I've become increasingly interested or excised about equality in science, which actually has led in turn for me to think more closely about the role that gender might play as a factor influencing MS development, particularly in terms of interacting with other factors. And actually maybe gender isn't just a neutral factor. It's not just that MS is more common in women than men, but actually trying to dig down and uncover why. So how can we use gender-specific characteristics to better understand MS? As I said earlier, there's the gender ratio in MS, and the ratio of women to men, so the number of women affected per one man affected is 3 to 4. So it's strikingly more common in women. Also, there are particular changes in MS or particular areas where we see differences between genders, and particularly at puberty, where obviously sex hormones start coming into play and the physical characteristics between men and women become more marked. During pregnancy, which is a life event that's limited to females, and then in menopause, again, an exclusively female aspect. And all of these seem to impact on MS development. And I think I'm going to talk more about this in more detail throughout this talk. There are obvious candidates for this, and when you look at the life stages, these are stages when hormones are particularly in flux. The obvious candidates are estrogen and testosterone. Estrogen can be thought of as an anti-inflammatory, but it's actually far more complex than this. It's a bit of a double-edged sword, and I'll come on to this in more detail later in the talk. So first of all, to think about this gender ratio in MS. So in 1900, if you look back to historical studies, then it was about 1 male per female that was affected. And over time, really since 1900, we've seen an increase in women compared to men. The overall prevalence, or the overall sort of commonness or number of people in the population diagnosed with MS has been increasing, but it's been increasing more steeply in women than men. It's generally thought that prior to the 1940s, this may have been at least in part related to improving healthcare access in women, and probably after this time as well. Routes to healthcare, how healthcare functions, has changed immeasurably over the past 100 years, and we can't ignore this in any studies that look at gender ratio. And it must be also interpreted in the context of healthcare access for different groups. However, there are a number of studies from a number of countries that have been more recent and really have occurred when there may have been more equality in healthcare. The majority of these have shown increasing MS in women. So when we talk about incidence, we talk about the number of patients or the number of people that are diagnosed with MS in a single year. And most studies show that the number of people diagnosed with MS in a year, the difference between the number of men and the number of women has been increasing, with it increasing more in women than men, although some studies do show no change. However, incidence does tend to fluctuate more because it's a year-on-year thing, but the reverse of this means that you can see changes over really a very short time period, which is why some of these studies that are quite short may actually show a genuine effect. I think that, you know, the fact that we're seeing these changes over such a small time period, you know, you look at sort of 1950, 2050 years, that's a single generation, tells us something about what might be driving this as well. Genetic changes we don't see making a difference that quickly. This is probably not something that's genetic, and we'll come on to that in time. However, if we're talking about environmental factors, this also is important because this means it can be very dependent on the population in question. People in different countries have different lifestyles, you get exposed to different things change at different rates. So it's really a very complex field. So trying to dig down into this variation a bit more, we say, well, we see it in some countries, we don't see it in other countries, there's variation in how quickly things are changing. Does this actually tell us something? Rather than just saying, well, it's different, it's a bit messy, don't know quite what to make of this, actually, can we learn anything from it scientifically? And this is work that's been done within the MS Base Registry, which is initially an Australian initiative that's now developed internationally and has given us some amazing insights into MS. It's taught us a lot about the patterns of MS internationally. It's taught us a lot about what is similar between countries, but this is a slightly different study looking at what is different between different regions or countries. And what it appears in this, it appears that actually in Northern Europe compared to Southern Europe, so the further away from the equator you travel, the sex ratio appears to be changing more. But this isn't happening with everyone with MS. This seems to be something when you start looking at its northern latitude, so the further from the equator countries, that you see the changes predominantly happening in relapsing remitting MS rather than primary progressive MS. So is this something that's actually you know, disease subtype specific or stage of disease specific? We know that relapsing remitting is generally thought of as more common in women, whereas primary progressive still has a gender ratio of about 1:1. There's often a higher inflammatory disease burden in relapsing remitting multiple sclerosis, and it's often diagnosed earlier in life. So again, these relapsing remitting and primary progressive MS are probably part of the same spectrum, but actually they seem to be behaving slightly different when you look at who's being diagnosed with these diseases, and importantly, and how this is changing over time. So as a scientist, my question is, well, what could be driving this change? It's all very well to observe things, but actually if you want to try and unpick causal pathways to MS, the kind of things that might be causing MS, then you look at the changes and you say, well, why are these things happening? When you look at gender or sex and MS, the first question that comes in is it all the X chromosome? Women have 2 X chromosomes, men have an X chromosome and a Y chromosome. Is it these 2 X chromosomes? Is there something about this? Is the Y chromosome protective against MS? You know, is there actually something in the genes that are underlying this? Now, genome-wide association studies have identified more than 200 genes that appear to impact on MS susceptibility. And what these studies do is they look at a huge number of people with MS. So you can see from my slide, they've got almost 50,000 people with MS. And they look at all the genes that are coded that appear to be doing something within all these people. And they look and they see which ones appear to be significantly different between people with MS and people without MS. For various reasons, looking at the X and Y chromosomes is hard, and it's only to get the results about this. It's been done relatively recently. And when looking at these, there's a single gene on the X chromosome that's identified. So across our chromosomes, we've got 233 genes, and actually only one sits on the X chromosome and none on the Y chromosome. Where you see this gene seems to be something to do with the immune system. It's associated with what we call T cells, which are an important part of the immune system and do seem to play a role in MS development. Interestingly, it's nothing to do with sex hormones. We know it's something to do with T cells, but we don't really know what the functional consequences. So what it actually does is, and this is very similar to a lot of the genes that are across the rest of the chromosome. So it doesn't seem like there's something special about the gene that's on the X chromosome compared to all the rest. Interestingly, some work that's been done in mice, so mice can be bred that are susceptible to MS, show that there may be some differences between where the chromosomes come from. So if the chromosomes come from the mum or the dad, but this really hasn't been replicated in humans and is very early work. So fine, we say it's probably not the genes that are driving this. And the reasons for this is we don't see things on the X or Y chromosome particularly. And also the changes are happening so quickly that this sort of biologically can't be only driven by genetics. As we come on to vitamin D, and as I think as probably most people listening to this talk will know, vitamin D is particularly of interest in MS. There's a huge amount of interest in this. There's a huge number of studies that have associated low levels of vitamin D with subsequent development of MS. And whilst we don't understand exactly how it acts, it does seem to be important. There is no established difference between serum vitamin D levels in men and women at a population level. So if you went out into the UK population, into the Australian population, and measured everyone's vitamin D levels, they're the same. There's no biological reason for them to be different. And that's the same also between sort of internationally. Also, increased vitamin D levels appears to protect against future MS in both women and also in men. So the effect of vitamin D, excuse me, the protective effect of vitamin D doesn't seem to differ by gender. However, is vitamin D deficiency more important in one gender than the other? And does it interact with sex hormones? Is there a mechanism that we can use to explain if vitamin D may have differential effect? Well, this is work that's been done in not in humans, but in cells and in animals. Vitamin D appears to decrease aromatase expression, and aromatase is responsible for the conversion of biologically inactive estrogens into active estrogens. So it influences estrogen synthesis from androgens, which in turn increases vitamin D receptor expression and enhances the downstream effects of vitamin D. So there is an interplay between the sex hormones and vitamin D, and with high estrogen enhancing the downstream effects of vitamin D. And actually, when we look at mice, and the reason for looking at this in mice is in animal studies, it's much easier to control how much vitamin D is going in and the behavior. And not all mouse work, and I don't do animal work myself, but not all mouse work can be translated directly into humans, but it does give us some insights into how the disease may develop or how it may behave. So I'm just going to talk through this study that shows that actually there may be differential effects between male and female mice. So the first thing that the authors do is they show that in mice, this group get vitamin D supplementation in their diet, and this group do not. So, and you can see that both in the male mice and the female mice, those that get supplemented with vitamin D have higher levels of vitamin D, and those without supplements have low levels of vitamin D. So there's no difference in the response to supplementation between male mice and female mice. Here we have the severity score of mouse MS, essentially. And what you can see is that in the mice who have, in the female mice, they use pink and blue, which slightly irritates me, but it makes it easier to look at. In the female mice who have high vitamin D supplementation, their disease appears to be less severe than the female mice who get low vitamin D supplementation. There's a significant difference between these groups. So there does appear to be a protective impact of vitamin D supplementation in the female mice, but you don't see this protective impact in the male mice, all of whom appear to get more severe disease. They then looked at a mouse model where the mice tend not to get mouse MS. And in those female mice who get vitamin D supplementation, they don't develop MS. However, in those that are vitamin D deficient, they do develop a sort of mild form of mouse MS. However, the male mice, you don't see a significant difference. There have been concerns around vitamin D toxicity in mice causing more severe MS, and that's been tracked back to actually being via calcium toxicity, where mice are really hypersupplemented. When the authors of this study looked at the calcium levels, they saw that the calcium levels were the same in mice who are receiving both lots of vitamin D and no vitamin D, which shows that actually, you know, in the levels, in the supplement kind of levels that we'd be taking in humans, this is not a calcium mediated phenomenon. This is not something that's being driven by calcium. And actually taking this a step further, and this is a different paper, but this looked at actually whether it's estrogen directly, rather than looking at just the sex, the mice, male versus female, actually looking at whether estrogen could be driving some of these effects. So in the first group, this is what we call the control group. So this is a group that we would expect to develop mouse MS. They've had, other than sort of being induced to develop mouse MS, there's been no other influences on these mice. They've got intact ovaries and produce estrogen at a normal level. And what we can see is that in the mice who have higher vitamin D, this is the black line, they have a milder disease course. And in the mice who've got low vitamin D, they have a more severe disease course. So these mice don't get supplemented, these mice do. So these are the high vitamin D mice with a milder disease course. They then took an identical group of mice, but removed their ovaries. And this removes estrogen production from these mice. So these are estrogen deficient mice. And what you see is the vitamin D effect disappears. So regardless or not of whether these mice get supplemented with vitamin D, they appear to have a more severe disease course. They then took a third group, and these mice had their ovaries removed, so they're not producing any of their own estrogen, but then they're supplemented with estrogen. So it's saying, well, actually, is it something else? Is it definitely the estrogen, or is it something else that's coming from the ovaries? Is it the effect of the operation to remove the ovaries that could be driving this? But actually, you see that when the estrogen comes back, you see the same pattern as in the first one. So you see that those who are supplemented and have higher vitamin D levels have a milder disease course, but those who aren't supplemented have a more severe disease course. And again, is there a reason for this? Do we think there's a biological mechanism underlying this? Well, vitamin D enhances the synthesis of estradiol, as I mentioned earlier, and that enables vitamin D and estrogen to actually act in synergy. So you get a greater effect of vitamin D in women. And so does vitamin D deficiency have a greater effect in women? And I think we don't have the data to answer that now. I think data looking at pre-symptomatic levels of vitamin D in the context of MS are very complex because we don't really know when it's important. Probably by the time you have MS, or even in the sort of few years beforehand, the process that sort of causes you to develop MS has already started. So it may be important earlier on. So I think there's a lot of unknown questions there, or unknown answers, I should say. The questions are known, but the answers are unknown. But there does seem to be some kind of interplay between estrogen and vitamin D. So taking this then a step further, well, during the female life course, when do we see fluctuations in estrogen level? And the most obvious one is pregnancy. So during pregnancy, estrogen levels rise. It's the highest level of estrogen you get during your life course. And we can see that actually during pregnancy, this is work that I did with Villiers in Melbourne earlier this year. During pregnancy, relapse rate falls, and then you get a rebound postpartum. And this is seen essentially in almost all pregnancy studies. So this is work that we did where we pooled the results from all the international pregnancy studies. And this did initially raise interest in the role of sex hormones in MS. However, it's really complicated to look at pregnancy. Pregnancy is also a stage of immune tolerance, and your immune system changes during pregnancy, and it changes postpartum as well. This is probably driven by fluctuations in sex hormone, but really neatly demonstrates the interaction between sex hormones and the immune system, which I think is very, very important in MS. Another association that's seen between sex hormones and MS is actually between the age of menarche, so the age at which women start their periods, and MS development. So interestingly, MS is associated with a younger age at menarche. So for each 1 year older you are when you start your periods, there's actually around a 13% reduction. So about 1 in 8, 13%, 1 in 8 reduction in the odds of MS. So this does seem, and this is in keeping with the importance of many environmental factors. And this is seen across various studies across various countries. So it can be seen in, this is a Canadian study, this is an Iranian study. So there's a number of studies where it's seen, and it seems to be an international phenomenon. And supporting this is the fact that actually in prepubertal pediatric onset MS, so in kids that get MS before the age of 13, the sex ratio is nowhere as strong. So actually it's equally as common in males and females. And then something seems to happen around puberty that really drives this increase in women over and above the increase in men. The question is whether this is driven by sex hormones or something else. And this was some really neat work that was done last year. And what the authors of this study did is they looked at the genetic factors that influence the age of puberty, because we know that the age at which somebody starts their periods is influenced by genetics, but it's also influenced by environment. As they looked at the genetic factors that but then they also looked at the genetic factors that influence obesity, because we know that increasing obesity is associated with an earlier age of puberty. And actually they found that the effect that we see in the population around earlier puberty, earlier starting periods, being associated with MS, perspective, and that really it's obesity that is driving this association that we see in the population. And I think this really shows this huge interaction between environmental factors, whereby you can observe something, but actually it's something completely different confounding this. And for the puberty observation, it does appear to be that obesity is confounding this to a significant degree. So if obesity is confounding the observation around age of puberty and age of period starting in women, is this an MS risk factor? Is this actually something that's driving MS? And this is work that Ben Jacobs, who's been working with me, did earlier this year. In Sweden, we see that in population studies, childhood obesity is relatively strongly associated with MS. But actually, it's relatively hard to study this, because again, sort of having children who have their body mass index or their weight measured during childhood who are then followed up for long enough, it's relatively unusual to see if they then develop with them, subsequently develop MS. It can be really quite hard. And actually, what we did is we looked at the genes underlying obesity and tried to separate them out into genes underlying adult obesity and genes underlying childhood obesity. And what we found that obesity overall appears to increase the, so genetically determined obesity appears to increase the risk of MS. But actually, if you look at only adult obesity, if you take out all the genes that are associated with childhood obesity, this effect gets smaller. But if you only include the variants, the genetic variants that drive childhood obesity, so if you really try and focus down on that, the impact of that appears to increase. And does this interplay with vitamin D? We know that there is an interplay between obesity and vitamin D, but actually in terms of MS, the two appear to be independent. It doesn't mean that they don't work together. It doesn't mean that if you are vitamin D deficient and have childhood obesity, your risk of MS becomes much larger, but it's not that the effect of obesity is being driven by low vitamin D or vice versa. So why is this important? Well, actually, there are increasing rates of severe obesity in women and men worldwide. So this first graph shows the increasing rates in men, but the second, far more striking graph shows the increasing rates in women. And this is seen internationally. This is not just a Western phenomenon, it's an everywhere phenomena. And it's seen far more starkly in women. So are we actually do we have a big problem on the horizon? And my feeling is that probably we do. The increasing rates of obesity, that changes in behaviour may well be leading to increasing rates of MS in future generations. And we see that obesity is more common in women than men, and actually there's sex-specific effects of obesity on top of this. Well, obesity is associated with high estradiol, the most biologically active estrogen in both men and women. It actually, in obesity you have more fat cells. These fat cells don't just sit there. They're not what we call biologically inert. They're actually doing stuff. They're very active. And one of the things that they do is they actually produce produced estrogens. So they're actually, what's the right word, creating or producing sex hormones. However, this does appear to be at different rates between men and women, and at higher rates in women. And actually the estrogens then feed back on themselves, and they are associated with more obesity development in women. So you get into a vicious circle. But also there are these downstream effects. And I think this is most well described in the cancer literature, actually. So obesity is very strongly associated with breast cancer, and this has been demonstrated both epidemiologically but also biologically. And a good example, a good way to think about this is actually when we think about HRT, and we very rarely now use unopposed estrogen as an HRT in women because of the cancer risk. So what I'm trying to say, and what I've hopefully convinced you with in these first few slides, is that we see differences in environmental risk factors, but we also start to see how they may be acting differently between men and women. A further risk factor is infection with the Epstein-Barr virus, and particularly infectious mononucleosis. So infectious mononucleosis or glandular fever is when someone's infected by Epstein-Barr virus during their teenage years. So infection in early childhood tends to be asymptomatic, but infection later on tends to be symptomatic. And I think most people know that infectious mononucleosis can make people really very unwell, but it can also double someone's subsequent risk of MS. And this has been shown in a huge multitude of studies. What we did is so this is work by Ashwin Khoury, who's a medical student who's been working with me, looking at data to look at both the age at which people seroconvert to Epstein-Barr, so the age at which people appear to be exposed to the virus, and then also the hospital admissions with infectious mononucleosis. And what he found that infectious mononucleosis is more common in men than women overall, but actually during the teenage years, so sort of from 10 to 19, it's more common in women. And this difference has been increasing over the years, so between 2002, 2006 to 9, and then more recently. So the difference between men and women has been increasing more and more. And alongside this, we've had increases in obesity. Now, why is this important? Well, this is Swedish data, and what this data shows, so this shows that individuals who have increased body mass index in adolescence, so those who have a body mass index of greater than 27, so who would be considered verging on obesity during their teenage years, and develop infectious mononucleosis after the age of 10, have significantly increased chance of MS compared to those who do not have infectious mononucleosis and who do not have a raised BMI. And actually their odds of developing MS is around 13. However, it's really important to note the very small numbers that are driving this. So there are 18 people with MS from a total pool of around 800 and 6 controls from a total pool of around 3,000. And so these are low numbers, but the effect is really very striking. And this is one of the problems that we face when we're doing research into risk factors in MS, is that no one thing is causal. Nothing gives you 100%. And to look at interactions, your numbers start to get so small, you have to really question how valid they are, but also, is there a mechanism? Can we explain why these numbers appear to be important? And I think this is important when we come on to look at smoking, because smoking is one of those factors that people say, well, you know, smoking habits have changed in men and women. More women are smoking now. You know, the proportions are very different. And is this driving changes in MS? So more women relative to men smoke since around 1940. That the gap has been changing. Actually, probably this may well not be driving the rapid increases that we're seeing, because the difference, certainly since 1970, has been driven by a greater decline in men than women. So it's not that more women are smoking, it's just that less and less men are, and the rate in women is getting lower at a much slower rate. So it's a question of really taking all the information into account. So to change tack slightly, I just wanted to have a couple of slides really thinking about sex hormones. We talked about environmental factors, and probably there is interactions. They act differently in different genders, but we've got to take the information sort of as a whole. You can't pick and choose. In terms of sex hormones, if you're thinking about how sex hormones might drive disease, the two that I'm really going to focus on is testosterone. I've mentioned estrogen earlier. So testosterone, the evidence for testosterone being protective, so the male sex hormone being protective against MS, is driven by the fact that there is a strong positive relationship between testicular hypofunction or low testosterone levels and the subsequent risk of MS. There's also some evidence for prenatal, so very early in life, testosterone levels driving subsequent MS risk. And studies in people with MS have shown that men with MS have a lower testosterone level. However, interpreting this is quite complex, because actually, similar to vitamin D, what is the effect of the disease? And actually, chronic disease in itself can lower testosterone in men. So I think that has to be interpreted with caution. However, this has led to clinical trials being performed. Testosterone is relatively safe. And there's possible effects on PASAT, which is a cognitive outcome, and brain atrophy in MS. And there's actually a biological mechanism that might explain why testosterone might have an effect in MS. And it's that it impacts on your immune system. So it changes the kind of immune cells that are around. It promotes Th2, so T helper 2 cells from Th1. And MS is traditionally thought to be Th1 mediated. There's larger studies going on at the moment, predominantly in France, to study this in more detail. And actually, what studies are there around sex hormones? So there's 2 randomized control trials looking at sex hormones as add-on therapies. 2 randomized control trials looking at estrogens as add-on therapies. One showed a significant effect, one showed no effect. There's a third one that's currently recruiting. But these have to be weighed up against the potential harmful effects I highlighted earlier. There are also, as I mentioned in the previous slide, some small studies as testosterone. Again, the risks are less than with unopposed estrogens, but they do need to be considered. Thinking about sex hormones as add-on therapy, the obvious next thought around that is, well, when do we use sex hormones as add-on therapies or as therapies in current clinical practice? And the answer is around HRT and the menopause. And I think menopause and MS is something that's really not covered in a huge amount of detail, is very understudied. The impact of menopause on MS, the impact of MS on menopause, there's very little out there. What does this do, both in terms of symptoms, but also in terms of disease course? I think my clinical experience certainly has been that many women report their MS seems to change around the time of menopause. Is this something that is definitely happening? Can we correlate this with MRI findings? Can we correlate this with objective disease activity? Studies just aren't there. And what we see is that decreasing estrogen levels lead to a variety of clinical manifestations or symptoms during menopause. And these may overlap with MS symptoms, or they may cause a transient worsening. So particularly things like hot flushes, and they can cause symptoms that are usually associated with heat sensitivity. Many people with MS say that things get much worse in the hot weather, particularly hot, humid weather. And actually we can see this in menopause, that in the context of hot flushes, actually people's MS impacts on their daily lives far more significantly. When trying to look at whether menopause is associated with a change in how MS behaves in the longer term, it's actually very difficult to dissect out. And the reason it's very difficult to tell is that actually dissecting out, so telling the difference between what's being caused by menopause and what's being caused by normal, in inverted commas, aging, is very hard because the two are inextricably linked. And there's a huge number of factors that need to be taken into account, such as the age in onset, the number of years that somebody's had MS for, whether they receive HRT, what disease modifying therapy, if any, they're receiving. And you need large numbers, and you actually need a design that starts sort of pre-menopause and follows people up for many years to best understand this. And also it's often something that neurologists don't really ask about, so it's very poorly recorded in the medical notes. The follow-up's needed really to differentiate between these transient worsening, where things can be really awful and then get better, and actually change in MS with longer term implications over 5-10 years. And it is woefully understudied. So how do all of these factors relate to MS epidemiology? Coming back to some of my work, I think there's a huge amount of interaction between many traditionally established MS risk factors and sex hormones. The pathways are all complex, the interactions are complex. It's not as simple as saying, well, this makes this worse, or this accelerates the impact of this. It's sadly not that simple. But the fact that risk factors may have different impact in different genders is actually relatively understudied. And actually looking at things separated by gender has probably not been done enough really in order to try and uncover this. And part of this is because, I put the title of the slide as a question, are there other factors that can influence this? But the answer is yes. We've had huge epidemiological shifts over the past century. The role of women, particularly in society, has changed massively, particularly since the Second World War, so particularly since the 1940s. And this has continued throughout the 20th and 21st century. Now women are far more educated, certainly in first world countries, and changing in more developing countries. It's a much more indoor and desk-based workforce. Overall, the way we live our lives has changed. We become much more indoors, we become much more sedentary. But also importantly, reproductive choice is now much more of a reality. It's very well documented outside the MS literature that there's far fewer pregnancies. Women are getting pregnant far later in life in general. Reproductive choice has gone from a dream to a reality, and I think this has hugely impacted on society as a whole. Alongside this, we've had changes in other factors, and I've just really picked out a few, but there are almost countless of these. So the increasing use of skin block, both driven by skin cancer awareness, sunblock, both driven by skin cancer awareness, but also by the cosmetic industry. It's now almost impossible to buy cosmetics without sunblock within them. So we are really, we're living in a world, and this was unheard of 20 years ago, we're living in a world where our behavior changes so quickly. our epidemiology can't really keep up with it. And with increasing urbanization and pollution, our exposure to sunlight and vitamin D has changed. And I'm just going to sort of start wrapping up, really thinking about, is there a case for thinking about gender in the way we approach all of MS? So this is work that Riley Bove did quite recently, and what her and Maria Hutchins did is they looked at the landmark, in inverted commas, so the big randomized control trials of MS disease modifying therapies over the past 20 years. And they looked at whether gender was included in these as a covariate. And they found that in the overwhelming majority it wasn't. So in no study did they actually look at clinical features, demographic features, and by demographic features we mean age, sort of level of education, those aspects, or clinical features such as MRI activity, EDSS. Nowhere were these compared by gender, so we don't even know if the male and female populations entering these studies were the same or different. About a third had sex-based subgroup efficacy analysis, so only a third of studies actually looked at whether treatments differed in their efficacy between men and women. And none looked at whether adverse events, or whether the harm that people come to as a result of therapy is different between men and women. None commented on the statistical power, so whether they were actually able to look at these properly. And also, older adults were excluded in all trials. So there was no ability to examine the postmenopausal hormonal changes. And why is this important? Well, there are physiological differences. The way that men and women are made is different. It's fundamentally different. There are different sex hormones. In general, men have a higher body surface area. The cardiac output is higher in men. Levels of plasma protein and drug binding are different. Women are not just smaller men in the same way that children are just not mini adults in terms of medicine. You know, the way their bodies work is different. And there are huge hormonal effects on drug breakdown and excretion. I think one thing that was relatively reassuring to me, and I didn't expect to see from this paper, was that actually around 2/3 of participants in randomized control trials were female, reflecting roughly the distribution of MS. Treatment naive patients are overrepresented, but that's because the majority of drug trials look at first treatment. There's far fewer trials that actually look at treatment switching. And the reason that this is a concern, and you know, if you believe some of the literature may not have been thought about, is actually that women scientists are very underrepresented in the design and carrying out of clinical trials. So in the phase 3 trials, these are big trials that influence prescribing. The overwhelming majority of authors are male. And there is a sort of systematic bias within the literature, which is beyond the scope of this talk, but is very well described and probably impacts on what's being looked at in studies. And I think at this point it's really important to say, don't forget other demographic characteristics. You know, I've talked a lot about women, and that's the focus of this talk really. But I think, you know, over the past year, particularly, and prior to this as well, but it's really become a big focus. We need to assume that everyone is the same, and this is work that I did earlier this year where showed that MS risk factors such as smoking appear to have different influences depending on ethnicity, and if you don't look, you don't see. And does this influence research priorities? And of course it does. If you don't look, you don't see. People approach research from their own particular background. You know, I'm female, I've got particular interest in this, and probably my interest in this is partly because I'm a female scientist and I'm aware that this has been a barrier. And I hope this book is available in Australia, but I would commend everyone who's interested to go out and read this book by Caroline Criado Perez, Invisible Women, which really drills down into how so much of our society is biased, and an invisible bias, and that so many things are designed for one gender and the other gender is ignored, and that studies don't provide sex or gender disaggregated data, so you can't actually even start looking for differences between men and women. And the book was shocking, but it's absolutely wonderful. And so this is my final slide, so I'd like to thank you for listening. I think my take-home messages are really that there's increasing research on environmental modifications to MS risk, but we actually need to really start drilling down and studying why these appear to act differently between sexes. And we can learn from these differences in MS susceptibility. It can tell us things about what causes MS. And we need to, as clinical researchers, make absolutely sure that our research is representative, because I've left this the question, can we move from trials to all real-world patients? It's a slightly loaded question. My feeling is we can't, because we don't include enough representative patients in our studies, and we need to listen to what others are saying. Just because it's not happening to you doesn't mean it's not happening. And I think we've got, in science, better at listening to patients, but we've got a long way to go. We need to get better at listening to all patients, not just those with the loudest voices at times, and not just entering into echo chambers where we reassure ourselves that we're doing the right thing, but actually to take all of these factors into account. So thank you for listening to me. I hope you enjoyed the talk, and I'm going to hand back over now.
That's been wonderful, Ruth. Thank you so much. Can I throw a couple of questions to you?
Of course. Hang on, let me just sort out my get my slideshow down. There we go. Yeah, go for it.
From all your research, which I've got to say is just so encouraging, the detail and the depth that you look at, what would you hope that your research will change?
So I think there's a few things. I think there's short-term hopes and longer-term hopes. Yes. And the short-term hopes are the ones that I hope to be able to achieve soon. I think soon I hope that I'll be able to actually partly get a discourse around this, to get people talking about actually the implication of gender in MS, and really to uncover some of the factors that lead to people developing MS. You know, why do people get MS, and actually to improve the care for people with MS as well. You know, if we know what causes it, if we know what maybe makes MS more severe, if we know what's associated with harms from treatment and those kind of things, then we can improve the lot for people with MS and also their families. I hope that, you know, in the long term, and this is the really long term, that I'll be able to uncover some factors that potentially influence MS development, and be able to inform strategies to reduce these, and hopefully, you know, impact on actually who's getting MS in the future. But that's something that's going to sort of take, you know, potentially a generation to come in. So that's a hugely long-term aim. But I think it's only really by uncovering what leads to people getting MS and what leads to MS being more severe that we can start to unpick that.
Absolutely. What would be your advice if you had a really good close girlfriend diagnosed with MS? Would there be some key things that you would advise them?
So I think it's hard to answer those kind of questions, because everyone's MS is different, and I think that's really, you know, that's really one key point, that everyone's MS is different and everyone's life is different. And MS is, I feel very strongly that MS is not the only thing that defines a person. They're also a person. I think that there's a few things that are key, and I think, you know, really the key thing is saying that MS does not define your life. It's going to be part of your life. It's not going to be something you can get rid of, but you should try not to let it define everything that you do in a negative way. So I think that's really key. I think that effective treatment is really key. So I'm a strong believer in, you know, hit it hard, hit it early. So actually, you know, effective treatment from an early stage. And I think a thing that I say to a lot of my patients is that MS doesn't mean you can't do things. It just means that you maybe have to plan them better or differently. And this comes on to a lot of the stuff that I've been doing around pregnancy and about reproductive health. It doesn't mean, you know, doesn't mean that you can't have a baby. It doesn't mean that it should have, you know, an impact on your family planning. It just probably means that you need to plan a little more effectively than you maybe would have done otherwise. And you know, for some people that doesn't mean planning more at all, because some people are by nature planners, and that's fine. But if you're not necessarily a planner, I think it's just, you know, and just having that sort of, you know, not doing things but planning things.
Yeah.
So I think that's sort of the main things is treatment is important to prevent long-term disability, even if you don't want it now, even if things don't seem that bad now. Effective treatment is key, and I think that's why we're not seeing the same cohort of people in clinics that we were seeing 40 years ago.
Yeah. Thank you so much. Thank you for sharing your time with us today. Thank you for all the nuanced arrangements we had to make to get this to happen. But Ruth, thank you for your commitment to research in MS. The level of detail in your research is really mind-blowing for me as a non-research scientific kind of person. And so I am really thankful that we have people of your caliber doing this research that will make a difference in now and in the future. So we want to add our thanks from the other side of the world. Thank you so much.
Well, thank you for letting me talk. All right, it's been really fun actually drawing up the talk as well. It always makes you think when you write these things. It's been good.
It does indeed. Yeah. Thank you again. That's great. I hope you've appreciated Ruth and all what she's shared with us today. If you want to speak to someone at MS Connect, they're there waiting for phone calls, and there's a whole lot of reasons to call them. And I'd also just like to reinforce the benefits of peer support, talking to other people who are also living with MS, who have been trained as peers and can talk to you on the phone, or maybe you want to join a group so that you can talk in more, you know, get lots of people's ideas and share opinions, either through the face-to-face groups or the telephone-based groups, or there are now some meeting online as well. Please make that connection. The peer support team are there to support you as well. And just a couple of other things to point out to you. Employment Support Service, that's here to support you in maintaining your work. And we are a registered NDIS provider, and we can also give you some guidance around My Aged Care if you're over 65. So thank you for being part of today's webinar and this week of programs for Women's Health Week. There'll be a short survey after this webinar finishes, and we'd appreciate your feedback. Thanks everyone for being online.